Good morning, dear students. Today we are going to discuss pre-operative measures, means the things, measures to be taken before any surgical procedure. Objective of today's lecture is to know fundamentals and basics of pre-operative measures, actual application of these measures on surgical team, on patient, and on surgical complex, OT complex. I'll share my PPT and explain each point. Please listen carefully, understand carefully. If you have any query, any problem, you can ask me after the session. Thank you. Any operative procedure, say major, minor, can be divided into three parts. Pre-operative measures means the things to be taken before operations. Measures are to be taken before operations. Operative procedure means actual operative procedure. Post-operative care means after procedure the care is to be taken. Success and failure of any operative surgical procedure totally depends on these three parts. Each part has got its own importance. One cannot ignore, one cannot ignore or skip any of these parts. So every part is important. Maybe pre-operative procedure, actual operation, and post-operative care. Myself, Dr. Sumit Vasnik, working as a professor, head of the department, postgraduate guide, PhD guide in Department of Surgery, PMT Ayurved College, Shevgaon, District Ahmednagar. So today's topic is pre-operative measures. We will cover pre-operative measures of the patient. In this particular heading, the first point is diagnosis, workup, fitness, admission means IPD, history sheet means case paper, written consent, injection TT, drug sensitivity test, pre-medication in the ward, IV line, needle by mouth, part preparation, shifting to the operation theatre complex, pre-medication in operation theatre, shifting in actual procedure room, anesthesia, position, painting means cleaning the parts, and draping means covering the parts. The first and foremost part of pre-operative procedure is a diagnosis. For diagnosis, actual operation is totally depends on diagnosis. You can plan surgical procedure as per diagnosis. For diagnosis purpose, detailed history must be taken. In detail, history must be taken. Differential diagnosis, differential conditions should be kept in the mind. Then provisional diagnosis is made, and lastly diagnosis is confirmed by detailed history, examination, second opinion. It is important to plan surgical procedure. Diagnosis is always important to plan surgical procedure. Always try to diagnose patient before taking to the surgical procedure. After diagnosis, go for workup. All appropriate investigations should be done. All appropriate investigations should be done. Investigations are supportive tools. Investigations, in fact, are compulsory for medical legal purpose. Avoid unnecessarily investigations. Second opinion must be taken if needed, and after operation, whatever you excise or remove, it should be sent for histopath to again confirm diagnosis. After investigations, fitness is compulsory. Fitness is of two types: physician fitness and anesthetic fitness. Both fitness should be taken. It is compulsory and customary to have fitness before any surgical procedure. It can be my major procedure, it can be minor. For medico legal aspect, fitness is important. Before fitness, complete workup should be done. Then patient is referred to physician for medical point of view. Physician will examine patient thoroughly and uh, after clinical findings that will be written in on paper, fitness paper, and he should mention whether the patient is fit or unfit for surgery, or he should also mention the things to be corrected. After physician fitness, the patient should be seen by anesthetic prior to surgery. In view of anesthesia, anesthesiologist should examine patient thoroughly and completely. In case second opinion should be taken. After diagnosis, after workup, after fitness, patient should be admitted 1 or 2 days prior to major surgery, and in case of minor surgery uh, on previous evening or same day in the morning, but patient should be admitted. Why patient should be admitted? Patient will get familiar to and adjust to surrounding and medical team. Admission, patient will be after admission, case paper or history sheet should be written completely. One has to mention all present details. It has got medico legal value. Duly history sheet duly should be duly signed with date and timing by consultant or surgeon. Then written consent. This is important documents in every surgical procedure, in every surgical branch. It has got medico legal value and ethical value also. Written consent should be in patient's language. If patient is illiterate, you should explain in his or her language. Patient should read before signing written consent. Avoid hard technical terms. Written consent should be signed by patient with left thumb impression of the patient, also impression and sign of close relative, and witness with date and time. Now, what are the pre-medication given to the patient in the ward? First thing, TT. Injection TT 0.5 ml IM stat should be given prior to every surgical procedure. If patient is posted for major surgery, abdominal surgery, laxative should be given so that bowel should be evacuated. If patient is anxious, anxiolytic drug should be given prior to surgery. It is better to give antibiotic before surgical procedure to prevent infection. As patient is kept NBM, so antiemetic and proton pump inhibitor should be given. Drug sensitivity should be taken whatever drug you are going to use for anesthesia or any higher antibiotics. Bowel preparation. Enema should be given prior to surgery, before evening and early in the morning on the day of surgery. Drug sensitivity. History should be taken in detail whether the patient is sensitive to any drug, allergic to any drug, food particle, dust, etc. Because if patient is allergic to any drug, he can be allergic to another drug also. You should keep it in mind. Sensitivity test is taken on left forearm lateral side. 0.1 ml drug is given subcutaneously. Make a circle, write down their date and time, and watch for any symptoms and signs. Though procedure is major or minor, IV line should be prepared. So you should, this is must, IV line is must. Always select straight and big vein opposite to operative site. Shave the part. Use bore gauge cannula number 18 or 20. Fix it. Then kneel by mouth. Kneel by mouth means patient is not given anything, either liquid or solid, 6 to 8 hours before surgery. So NBM should be adequate 6 to 8 hours prior. One must confirm whether the patient is NBM or not. It should be followed strictly. If it is not followed strictly, it can be dangerous during anesthesia, during operative procedure. Part preparation. Clean bath should be taken by patient early in the morning or before the procedure. Shave operative field widely. Clean inners, clean clothes. There should not be any infection, skin infection around the operative field. Then patient should be shifted to operation theatre complex 1 to 2 hours up to 3 hours prior to surgery. In OT complex, patient is kept in pre-operative room. His regular casual clothes should be changed. OT gown should be given to the patient. You will have to reassure patient. One has to monitor vitals of the patient. Pre-operative notes should be mentioned by junior doctors or assistant doctors. Pre-medication in OT. So there are certain drugs to be given in operation theatre before operation. Injection atropine 1 ml. It contains 0.65 mg of the atropine sulfate drug. It is a vagolytic drug to prevent bradycardia, to minimize secretions of the body. It should be given. It is a cardioprotective also. Injection 14 is given 1 ml. It is sedative, potent painkiller. Injection either diazepam or midazolam. Nowadays midazolam is used. Midazolam is given before operation to allay anxiety and panics of the patient. Injection ranitidine or any PPI means pantoprazole should be given to avoid acidity or hyperacidity as patient is kept NBM. Injection ondansetron is given to prevent nausea vomiting during procedure. IV antibiotic is compulsory for every patient before operation to prevent infection. IV fluid should be given to the patient as patient is fasting. So to start with, glucose should be given, and in operation theatre either glucose or IVRL should be given as per procedure or anesthesia. Now patient should be shifted in actual procedure room before few 20 to 30 minutes. Surgical team should reassure patient. Patient should be laid on operation table. We will have to connect 5 parameters, 5 paramonitor, and you should watch vitals of the patient. Now anesthesiologist should come into role. Anesthesia can be general anesthesia, spinal anesthesia, local anesthesia with or without sedation as per procedure, as per disease, as per patient's condition. All anesthetic drugs should be ready. Instrument and equipment also should be ready. An anesthesiologist is also known as peri-operative physician, means he has to take care of patient before operation, during operative procedure, and after operation also. Before, during procedure, or as when procedure is over, anesthesiologist may the should mention, should put down, should write down anesthesia notes on the history sheet. After giving appropriate anesthesia, suitable position should be given to have good access to the surgeon. There should be good light source, there should be technical support, and patient should be comfortable. After giving position, cleaning with antiseptic solution like Savlon, betadine spirit to, to the operative field. Avoid spirit in open wounds, eye, chest, and anal region. Cleaning should be from operative field central to periphery, and you should dry lastly the area. Now, draping of the part. Cover all parts except operative field. Sterile plain sheet, cut sheets, abdominal sheets, or leggings should be used. Expose only operative field and complete cover other part. So no touch technique. So without surgical team, no one should be allowed to touch these sheets. So preoperative measures actually start when patient comes to OPD for your consultation to draping of the operative field. Thank you.